Okay, so yeah, I'm Katie. I'm one of the addiction medicine fellows at the University of Minnesota, and today I'll be talking about Brixadi. And specifically, I'll be discussing this article, the early emergency department experience with 7-day extended release injectable buprenorphine for opioid use disorder. So the aim of this article was to describe the pharmacokinetics of the 7-day extended release bupe formulation, which is Brixadi, and specifically discuss the practicality of the use in an emergency department setting, discuss the early experiences that the emergency room settings have had with this medication, and in the context of the ongoing ED innovation clinical trial. The article is important as there's an urgent need for additional treatment options for OUD and addressing common current barriers to care, getting scheduled to follow-up, transportation, ability to send prescriptions. So the ED innovation trial is a multi-site study funded by the NIH HEAL initiative effort. The goal is to increase access to medication for OUD in general medical settings and expand access overall to ED-initiated buprenorphine. There are 28 diverse EDs involved in the study currently, and actually in Minnesota, HCMC is one of the sites. They're both in urban and suburban areas and academic and community settings. The randomized clinical trial, which is enrolling individuals with OUD and comparing the traditional sublingual bupe initiations with this Brixadi, which is the 7-day extended release bupe injectable. And they were specifically looking at the outcomes of engagement and treatment at days 7 and 30. So far, there's been 1,600 patients enrolled, and that was between 2020 and 2023. To qualify or to be enrolled, patients needed to be at least 18 years old with untreated OUD. They needed to be English speaking and be in at least mild opioid withdrawal. They're looking for a CAL score of at least 4. Half of the patients received the extended release bupe, and only 3% of eligible individuals refused the randomization.
So these were all people coming to the emergency room,
Yep.
correct?
Mm-hmm. So patients in the emergency room received a single 24 milligram weekly injection dose. I'll talk about dosing later in the presentation. They did not receive an additional prescription for sublingual bupe. Oh, I already talked about it. 16 milligrams. So 24 milligrams of the weekly injection is equivalent to the 16 milligrams of sublingual for the week-long prescription. Patients on average were observed for about 2 hours in the emergency department after receiving the injection, so not a long stay. And then they were all discharged with a follow-up appointment to an addiction medicine treatment program within 7 days. And that was scheduled prior to them leaving the emergency room. So initial clinical trials that looked at Brixadi demonstrated non-inferiority compared to sublingual. So the clinical trial that was reported for the FDA application, the investigational drug was called CAM 2038. And they found that the response rate was non-inferior. And then the same study actually found the CAM 2038 to be superior to the sublingual on the mean percentage of opioid negative urine samples for weeks 4 to 24. And then there were similar outcomes between the extended release and the sublingual in retention of treatment, desire to use opioids, and the severity of withdrawal symptoms. An additional early clinical trial showed that the rates of retention and care for patients receiving Brixadi was actually really high at 73.6% at 48 weeks. And the majority of the patients in the study actually reported the injection to be much better than previous sublingual bupe treatment. 3% did indicate that it was worse. So, extended release buprenorphine. Many of us are familiar with Sublocade, which has been on the market for several years now. This presentation and study was specifically looking at the newer extended release preparation Brixadi, which comes in both weekly and monthly formulation. This study was specifically looking at the 7-day extended release injectable bupe, and there's definitely more literature on the 7-day compared to the monthly version. Oh, like I said previously, called CAM 2038. It was approved by the European Medicines Agency in 2018 for actually those 16 years and older. And then the US FDA approved it for 18 years and older in 2023 for patients with moderate to severe opioid use disorder. This is a busy slide, but some additional information comparing the two. So the 7-day extended release bupe, the bioavailability is quite a bit higher than sublingual, 6 to 8 times, and so a lower dose is needed to achieve an equivalent plasma concentration. Half-life is between 70 to 107 hours compared to the sublingual, which is 32 for a terminal half-life. And then the safety profile is very similar with the exception of the 7-day extended release being associated with some mild to moderate injection pain. So it's a viscous liquid crystalline gel, which encapsulates the bupe solution. Over time, that gel biodegrades, which releases the bupe at a steady rate over a week-long period. And it's nice because similar to Sublocade, it avoids those daily peaks and drops associated with the daily sublingual dosing. And it comes in pre-filled syringes, all small volumes, less than 1 milliliter. And then we can't see this, but it's a small IV, I believe the 23 gauge. So how to start Brixadi. So their package insert is actually different than what was described in the study that I reviewed. So in their package insert, they said that for patients who are not currently on any kind of treatment with buprenorphine, you would start with a 24 milligram Brixadi weekly dose. What they recommend is starting with a sublingual dose of 4 milligrams and making sure that the patient tolerates that dose. And if they do not experience precipitated withdrawal, then giving a first injection of 16 milligrams, and then within 3 days, giving an additional dose of 8 milligrams, which is interesting and I would say quite a bit more complicated than what this study described. And I think the study results are more encouraging for an easier start and transition. But this is what Brixadi on their package insert recommend.
So to recap this study, they did not give any sublingual ahead of time, and they gave all 24 at once.
Yes.
Right.
Yes, and then you can increase the dose weekly. They didn't say by a specific amount, but the maximum dose is 32 milligrams.
But the study did take that while they were in withdrawal. I can't remember.
They had to be in at least
They had
a
to
cows
do
greater
it.
than 4.
But just 4 was. the
And
only-
this we'll talk about later. They had
Yeah,
some
yeah,
patients
yeah,
that
yeah.
were actually lower. They did some separate precipitated withdrawal trials on.
Okay.
Yeah. So this is a comparison in the plasma concentrations, comparing sublingual and then to weekly dosing and monthly dosing. So if you already have a patient on sublingual, this is a helpful chart for comparing how to start a weekly injection versus a monthly injection. And one thing that we noticed to kind of simplify and conceptualize this, it seems that comparing the sublingual dosing to the weekly, it approximately is a double of the dose. So less than 6, you're going to start at 8, somewhere between 8 to 10, 16, 12 to 16, 24, and then I believe this is 18 to 24 is a 32. I'm sorry. And then comparing the weekly to the monthly is just a 4 times higher dose. So this is comparing the plasma concentration of Brixadi compared to sublingual bupe, specifically looking at a 16 milligram dose versus that 24 milligram injection. And as you can see, the initial plasma concentration is much higher with the sublingual dose. You see the large increase and then taper versus Brixadi is a slower onset over time, which is nice, less concerning for a precipitated withdrawal, which we did see in this study. So precipitated withdrawal, only 4 patients who received the extended release bupe experienced precipitated withdrawal, which was 0.5%. There weren't any defining characteristics predictive of who might experience precipitated withdrawal. They did note that all patients who had precipitated withdrawal had fentanyl in their urine testing, but 76% of the patients in the study also had fentanyl in their urine testing. So additional study looking at the risk of precipitated withdrawal. This study was actually pretty interesting because it was studying the Brixadi injectable for patients with minimal to mild opioid withdrawal. So the article that we've been discussing, patients needed to have a COW score of 4. For this study, they could have a score of 0. And they were looking at the rates of precipitated withdrawal. And they found that 7% of patients experienced precipitated withdrawal, only 3% with those higher scores, 4 to 7, but a significantly higher number with lower scores, so 14% in those that had a COW score of 0 to 3. So what they found was that the 7-day extended release bupe may be feasible in patients with OUD presenting with minimal to mild COW scores, specifically at least 4. So didn't recommend starting for scores less than 4. Okay, so again, the study that I was looking at was specifically looking at the 7-day version of Brixadi. There's not as much literature on the 28-day version of Brixadi. But what we do know comparing this to Sublocade, first of all, it's difficult because both the X and Y axes of these are different. So difficult to make exact comparisons. And we also don't know the stacking effect yet that Brixadi monthly injections have. We know that with Sublocade, especially with the 300 milligram injections, we get that stacking effect over time. And we just don't have that data yet that I'm aware of for the monthly Brixadi. What we do think is that the gradual taper or decrease in plasma concentration does seem to decrease faster in the Brixadi compared to Sublocade. But definitely we'll need more studies, more information on this over time. Okay. So logistics of implementing Brixadi in the emergency room. So for this study, emergency room nurses were trained to administer the extended release bupe. It really required minimal additional training as it's very similar to other injectables like Lovenox. It's really nice because it doesn't require refrigeration, so easier to have in the emergency department or a clinic setting. These are the injection sites that are recommended. You can also inject into the arm, but they recommend not doing that until you reach a steady state, which they noted as 4 consecutive doses. Otherwise, it was associated with a 10% lower plasma level in the arm compared to other regions. In this study, those that presented to the
Code 21, West Building, Adult Emergency Department.
Pause.
Sorry,
first
pause.
floor, room
Pause and think of
16.
any questions, yeah.
Code 21, West Building, Adult Emergency Department, first floor, room 16C. Code 21, West Building, Adult Emergency Department, first floor, room 16C.
All right. So in the study, all patients were set up with a referral to a community provider or a treatment program for OUD prior to discharging from the emergency room, and all had specific scheduled appointments. And also
Code 21, West Building, Adult Emergency Department, first floor, room 16, C as in Charlie. Code 21, West Building, Adult Emergency Department, first floor, room 16, Charlie. Code 21, West Building, Adult Emergency Department, first floor, room 16C.
Also had information in their discharge instructions, noting that they had received the injection, the expected duration of effect, and also a recommendation to the referral clinician to resume or initiate a bup of sim formulation prior to day 8. Okay. So briefly reviewing the REMS required for Brixadi. So it's only available through the restricted distributions program. Can never be directly dispensed to a patient. Only administered by healthcare professionals. So they note that prescribers are not required to be certified by the Brixadi REMS to prescribe this. Interestingly, they said that prescribers can obtain Brixadi for specific patients that are scheduled by writing a prescription, sending it to a REMS certified pharmacy, and then that pharmacy coordinating delivery to the prescriber, administering the Brixadi at the patient's appointment date. I'm not sure how in practicality that would work, but that is what they noted. But they said for prescribers that intend to keep a supply of Brixadi, that you need to get certified and have your healthcare setting certified through the Brixadi REMS. Okay. So key takeaways from this paper. First of all, majority of patients tolerated the medication well, even with very low COW scores of 4. Lower than oftentimes what we consider a full dose initiation for sublingual bup. We often don't start until a COW score of 8. Precipitated withdrawal was rare, and it allowed to break down some of those patient barriers and clinician concerns by giving a medication that lasts for a prolonged period of time. Patients don't need to go pick up a prescription right after. And it gives additional time between a patient needing an appointment. So especially with just access in general to care, that gives us a little bit more of a barrier. And then had a relatively rapid onset, positive clinical effects. They also noted that for patients that are in severe withdrawal, they may need an additional sublingual bup rescue dose to help with symptom management. And then they noted that there's really a potential to improve engagement and overall care, meeting that critical threshold and stabilizing a patient early with a direct referral. That is what I have.
There's chat if he comes.
Any questions?
You said the majority of patients liked it over sublingual bup, but did they say why?
Not in specifics. I think this article quoted a couple patients. Yeah,
I think the survey
Let 'em
saying,
know.
do you prefer one or the other? Right? It's kind of one of those kind of questions. Surveys, just yeah.
I feel like patients tend to be very like driven one way or another if they prefer like taking a medication or like a long acting injectable. Like, a bunch of patients don't want an injectable, so I'm surprised so many preferred it, but
Yeah. Yeah, that was in the clinical. Or is that no, this one?
I think that
clinical
was
trial.
in the clinical trial.
That's never quite as
Yeah.
applicable to
think
reality,
a
right? Like the
couple-
retention rate was 74%, which we probably won't see.
Yeah.
You know, in practice.
I think privacy was one thing that was noted. Not having to have the prescription.
7-day instead of the 28-day. Good question.
They did not.
I wonder if it was because it's ED. And so you don't know maybe what your dose is gonna be a week from now. You're gonna get them connected within a week. You have more dose flexibility with Brixadi than you do with certainly with Sublocade, but, you know, at that point, then at the 7-day, the choice, I guess, you could then go to the 28-day or.
No.
28-day requires 7 days of stability before starting.
For the Brixadi, you're saying?
Yeah, so that's very similar to the Sublocade. So the 7-day does not, and so that makes it a little more applicable for a quicker start from the ED setting.
And I'm hopeful that they'll eventually remove that, because it'd be nice to be able to give people a full month coverage if it's hard to get access to care. But I don't know if that will go away.
So the reason why there isn't more precipitated withdrawal with Brixadi is,
I think the slower onset.
Slower onset, right?
That's the thought process, yes.
Mhm.
Mhm.
Yeah, okay. Over
Hours.
hours, 8 hours.
But then that also means if somebody is really in significant withdrawal, they may not get relief from that withdrawal very quickly, which is
Maybe.
why,
Sublingual.
presumably why they say you can give a sublingual dose, a rescue sublingual dose.
Yep.
Mhm.
Okay.
I mean, even if you gave more Brixadi, it would still take a while to kick in. So, yeah.
Mm-hmm. So, yeah, but the slower onset, is, but someone says the 28-day doesn't have the slower onset?
We were
Is that
trying to
right?
confirm some of this. It says maybe not as much, but we couldn't find the exact hourly peaks.
Yeah.
If anyone has seen that, let us know.
Hmm.
By days.
Yeah,
either.
it seems to have and even the article mentions that it potentially has a faster onset, but we couldn't find the exact
Okay.
series per hour. Maybe it's out there, but we couldn't find it. And Brian, Grant, and us, everyone else looked at it too, and we couldn't find it. So,
Mhm.
Yeah.
Has anyone here used Brixadi out of curiosity at their center?
Is it approved anywhere? Is it,
Yeah.
I mean, any of the
Yeah.
formularies?
This is being used in the West Bank ED right now,
Yep.
Hmm,
sort of under a pilot project.
uh-huh. So that's the only place in Fairview?
Yeah, we've
That
had a couple of those patients come up to 3A after they've gotten it. It's been really helpful.
Nice. Okay.
The
And do
challenge is
they,
the continuation of,
yeah, then what? Do you continue it, if they've been started on it?
nope, unfortunately, the option, generally in the ED, they then get referred to the recovery clinic or other outpatient addiction med care. And they either need to switch over quickly to a site that can offer Sublocade, or they may have to go back on sublingual, but they've at least sort of, the thought is smoothed out that transition period with the 7-day product, and then go to the sublingual product after
our
being through the withdrawal
center-
period.
Our infusion center is not using Brixadi, or has it available?
Nope, just Sublocade currently.
And do you know what the barriers are with that?
Oh, so many, yes.
Yes.
Good.
Yes. Where to even start? The REMS program and the controlled substance status have added barriers at every possible turn with this. Currently, one of the main barriers is understanding, particularly for patients with MA, the formulary status of Brixadi. It appears to be listed as non-preferred, and when I've tried to get info, it has been that generally patients have to try and fail Sublocade first.
Oh,
But we haven't really been able to, I don't want to say test it out, but go through the prior auth process with patients, because we haven't yet implemented this in the infusion center. There's already questions about, do you really need an infusion center and chair time for a simple sub-Q injection? The reason it's currently set that way within the Fairview system is because of the REMS program and the barriers to obtaining this medication for individual clinics and taking this on as a controlled substance.
We are navigating this, me, Danielle, and you know, countless other Fairview people in the recovery clinic. We have grant money to get this going in the clinic. Getting all the details arranged is another thing altogether, and no idea how soon it might happen. But that is on the books of you know, in the process of figuring that out, so we can hopefully use that experience to get better ways of understanding how to get the Medicaid coverage and how to make sure that people are able to actually have a sustainable source of this medication.
So, but the ED is using it.
Yep.
Right? And you said it's covered, or that's part of the pilot project. Is that a funded pilot project? Is that funded by?
Sure.
So I've been working on, I work at the Hennepin County Jail. I work for Hennepin Healthcare, right? HCMC. And I've been working on getting extended release buprenorphine, specifically Sublocade, but I'm sure it would apply to Brixadi as well, at the jail for like the last 6 or 8 months. I'm REMS certified. And actually the most difficult piece right now is getting the pharmacy distributor to send us the medication due to financial issues, due to lots of different barriers created by the REMS process initially. But it's way more complicated than I even imagined. I think sometimes what can happen within a hospital system is that the pharmacy can get this medication and keep it within the 4 walls of the hospital, which is why it's easier for the EDs to do it. But to have it at an outpatient clinic, you're not allowed to use your system to get that medication. You have to have the individual clinic REMS certified and medication sent there. It's a huge mess.
And unfortunately, the option of a clinic using a specialty pharmacy so that the clinic doesn't have to register with the REMS, it's all in the specialty pharmacy, is not allowed by a lot of health systems. It's white bagging and bringing in a product from an outside pharmacy. And so that is an additional barrier. And then it's also a controlled substance. So clinics don't have procedures in place to handle the controlled substance once it arrives on site. And if the patient doesn't show, that there's a whole slew of things.
We were able to overcome this with the Sublocade. I mean, it sounds like it's similar issues, right? And hasn't it been overcome with the Sublocade now or is it not? Is it still a problem?
Still not an easy process to get Sublocade at a site. No, I mean, that's what Elise was talking about, that it's a lot of barriers for them to get Sublocade. So.
But I thought Fairview was able to get it.
Infusion clinics. Yeah, the infusion center is doing it.
There's about 2 or 3 infusion centers that will offer it.
Okay.
Yeah.
Okay.
It's that you can get it within the hospital, but like any of like the outpatient clinics or anything that's outside of the 4 walls of the hospital, it's really difficult to get it, even though you're associated with the health system.
Yep.
I've been requesting to talk to the FDA about this whole thing, but haven't gotten to them yet.
Good luck.
Yeah.
And Danielle shared about the Tmax she found for the monthly product is 6 to 10 hours, so it is shorter. And I'll keep digging and see if I can find that hourly, and I'll send it out to people if I find it. But that's good to know. So it is shorter for the monthly compared to the weekly. Yep.
So if these patients, I mean, the patients in this study, for example, did they actually get follow-up? Or, I mean, if I would presume that other places have the same problem in terms of you know, accessing it in a clinic. So we don't know how many of them actually stayed on it or.
Well, it's an ongoing trial, right? So the one she's presenting is the ongoing. So they don't have all the final data published yet. This was just an early presentation of some initial data, mainly around the precipitated withdrawal and things that way in their experience.
I see.
Yeah. But
Um,
the CAM 2038 trials had good retention, but again, that was in a phase 3, different type of setting.
yeah. And that's what I was wondering too, if they're looking at how many actually come back
Yeah.
after 7 days for the follow-up, get on some other buprenorphine.
So they're tracking at what days?
They're tracking that here,
Yeah,
I would presume.
day 7 and day 30.
Yeah.
But it's not, the information on the results isn't in the paper yet.
I wonder.
I'm
how-
sorry, I couldn't hear you. The data isn't available.
Yeah, data's not available, but they're tracking day 7 and day 30 for follow-up.
Okay,
Do we have any sense
as
how
far
that's
as,
here?
as far as follow-up and also as far as still sober or,
Yeah, they're gonna
Yeah.
look at,
Yeah.
engagement, treatment retention, and I don't know the
Like
exact.
engagement and care.
Yeah, I
Yeah,
don't know if
but
they're
I-
doing it yet, double check, but yeah, didn't say in this initial article, I think. It might say the ED innovation, trial, like, posting on clinicaltrials.gov. You were asking.
Yeah, I was gonna say,
yeah.
any comments or do we know anything about how it's working here? Follow up from, the ED.
Ironically, that question was just asked among the group earlier today regarding numbers, so I think those are being updated. So that is being tracked through the ED team.
Pediatric Emergency Department,
Gotcha.
floor 2,
I'm sorry.
hallway.
They are tracking it.
They are
Code
tracking.
21,
Yeah.
South Building, Pediatric Emergency Department, floor 2, hallway. Code 21, South Building, Pediatric Emergency Department.
While this is going
Floor
on,
2,
just general side comment. If people want anything particularly presented during these monthly kind of rounds, please do chime in a topic. We have, learners, we have fellows, we have residents who are happy to delve into an interesting topic and present back on it. So do, give suggestions. Or
Code
if you want to present
21,
something yourself, you're more than
South
welcome to as
Building,
well. Yeah.
Pediatric Emergency Department,
Hmm.
floor 2, hallway.
um,
Code 21, South
yeah,
Building, Pediatric Emergency Department.
exactly. If anybody has ideas or topics,
Code 21,
um,
South
or is
Building.
willing to present, yeah, we're always
They have
open
their
to
own area of
that.
expertise. Yeah,
Hallway.
please. We love to learn.
Mhm.
At least had a question.
I had a question. I missed the beginning of this. I'm sorry, but were these patients, they were just coming to the emergency room with overdoses or with withdrawal or looking for help with their opiate use disorder or what?
Yeah, they didn't specify what the patients came to the emergency room with, but they qualified for the study if they had opioid use disorder and were not receiving treatment with buprenorphine. Or just
Whether or not they had previously had treatment.
Yep.
Mhm. And how about our emergency department? How are they deciding who to give this to? I mean, Fairview's emergency department, I should say.
So it's a patient presenting with opioid withdrawal or seeking help for opioid use disorder, and then ED engaging in conversations about treatment options.
Okay.
Are you guys doing any pre-dosing with sublingual, or are you just giving the Brixadi as well, just at?
I would.
Protocol requires 1 dose of sublingual.
Prize 1 dose, that's curious, gotcha.
Mhm.
Okay, and are you doing like the Brixadi packaging where you do like the 16 and the 8? Or how are you guys doing it?
I believe it's just a single dose of 8 milligrams that's required. I think they might do higher dosing depending on the situation, but
Okay.
that's the minimum.
Okay. Thanks, Alex.
Sorry, were you talking about giving sublingual 8 or 16?
Yeah.
Or you, okay, before you give the Brixadi?
Correct.
Thanks.
What dose of Brixadi are you doing in the ED? Is it variable depending on what you think they need, or are you guys giving a standard?
It's either the 24 or in some cases based on recent or historic use of sublingual buprenorphine, a 32 milligram.
Gotcha.
So
And
it was looking at the study and agreeing the package insert added another barrier with that 3-day sort of booster dose, which
Yeah,
seems silly looking at the
yeah,
Yeah, it
levels.
does.
yeah.
And do they have to have a cows of 4? Is that the minimum here?
I
Like
don't
study
remember the specifics.
cows?
I know that they have a protocol that has a cow's cutoff, but I don't remember the specific number.
Do they also have like a time since last fentanyl use? Or any, I mean, I don't know.
Yeah,
So I think,
I have something in my email I can try to send out to the group here.
yeah,
That'd be
I'd
good.
love to know what the protocol is that they're using here.
It is cows at least 4.
At least 4, but they're giving 8 of sublingual. And not precipitating withdrawal.
Sounds like we don't
Hmm.
know that.
I'm not sure if the sublingual is happening every time based on the situation. So it's in there as the recommendation based on the dosing of the weekly product, but it, yeah. It's
Cows
sort of
greater
that
than
provided-
equal to 4 is what I'm seeing here. And usually at least 6 hours from last use. But I'll send a screenshot here.
Interesting.
That's it?
Yeah,
Really? 6 hours. Wow, and we're not precipitating withdrawal.
Mhm.
That's interesting.
Yeah.
This is Chris, one of the fellows. It's more of maybe a basic question, but the reason we give for Sublocade a trial of a week of oral is because of the half-life it takes to get to the effective dose in serum typically. I'm wondering if my thought process is why we need that week of oral before the injection. If this is something that's useful for lasts for a week, and this is extending out, I know, the month when you can't do that. And this is my understanding is because we have to wait for it to get to a steady state for it to be effective.
So waiting a week on the sublingual is not needed, because we're not giving the Sublocade and the sublingual at the same time.
No. I mean,
Yeah.
like you start, if you're going to start with Sublocade, or in this case, start with a 1-month Brixadi, both of them are requiring oral buprenorphine to be started before you
Yeah.
give it. My question is
Why
that,
is the question?
yes.
Yeah,
So-
fair. I don't have a great answer as to, is it really, I mean, it's not really needed, I don't think. Unless someone has a greater answer, it's like,
Well,
should
I'm
we be
sure-
doing this? I
well,
mean,
Probably some of it is so that if you precipitate withdrawal,
we used to get more buprenorphine anyway. I mean,
It's listed as a test dose, so I don't know if they're waiting for an allergic reaction, like immediately to sublingual before you give them
that's
a
the
week
only
long.
thing. Yeah, if someone had a bad reaction to it, you don't want to be on a month-long dose. That's
Right.
the only real good reason not
Yeah.
to. But even side effects, you're not gonna know for a little while sometimes. You don't have immediate, but yeah, allergic reaction you would know. But if you just have side effects of buprenorphine, you wouldn't know that always immediately too.
Mhm.
So it's,
For ED, it's not like you need to take sublingual or naltrexone oral before starting dose.
no, you don't technically. So I don't know. If someone has a greater answer to like, is there really a need for this? I mean, especially if someone's been on buprenorphine before and has tolerated it.
I just shared the link, and specifically it says may consider test dose, and it doesn't have a test dose actually as part of the protocol. That has been what has been a typical plan and approach, but yeah.
Well, I'm hopeful this ED article, this ED innovations will show that it's okay to just start. Maybe that will open up down the line. I don't see a great need to do a week long of sublingual before you get Sublocade. I can't
Yeah.
find a great reason for that. If anyone knows of a reason that I'm missing, please let me know.
Yeah, and I think that was like what my question was kind of trying to get at, was
Yeah.
that part of the question.
Sadly, I think the most valid reason is because that's how it was studied.
Yeah,
Sounds about right.
yeah.
That's usually how these things work.
Yeah, but in practice, yeah, I can't think of a ongoing reason to have that rule still there. So hopefully this will help address that.
I'm finding at the jail that we're doing a little bit more being aware of xylazine withdrawal in a lot of these folks as well. And so then we're resolving their opioid withdrawal, but they're still super anxious, restless, irritable, and using a lot more clonidine, kind of help them through that time. So I think just something I'm thinking about with the Brixadi as well, making sure that, I don't know,
We
taking care of
don't misattribute, they're having ongoing withdrawal or precipitated withdrawal when it's just that xylazine picture. We were just talking today, we're giving clonidine much more often, and heck, even using benzos more often in our patients sometimes at Hennepin here and at Abbott, we've been talking about. Yeah. And
We're finding that at Gateway too. We have patients who have the xylazine in addition, and we give them more clonidine and more Valium than we would somebody just withdrawing from opiates.
It's pretty, I think Hennepin, Brian Granson had a message about that circulation, that they're seeing a lot of xylazine. It's gone way up.
Yeah, we do too.
Pretty saturated.
So then we may get more admissions on detox, even though we're not admitting purely for opioid, for instance. But if there's other substances on board.
I had a xylazine last week, and she very clearly said she's been testing her supply and knew there was xylazine in it.
We're seeing that a lot.
You don't admit to detox for opioids, do you?
No, but she had concurrent benzo withdrawal as well.
Yeah. And it's obviously hard to sort it all out, but yeah. We find patients that need treatment for both. Well, this is interesting and certainly holds some promise. I think patients, obviously the biggest issue is getting them back, right? Having them return for their injections. And this is better than, the induction we used to do with the sublingual as an outpatient, but it's still, I think, dependent on the patient being willing to get back for their next injection, right? And that's been a problem.
I do show up in the recovery clinic too, and it went well, and they want another injection, and now we say we don't have it for you.
Well, that's what they're hoping to have it.
Yeah, that's a problem. We have to have it.
But at least nothing else, I think someone mentioned earlier, if you get them a week of stability, that can be life-changing, right? So even if that gets them into the clinic to do sublingual if we have to, it can really still change the course. And hopefully we'll have, easier continuation, but minimum a week is worth it.
Couldn't they then convert to Sublocade right away?
Well, if you've gotten that.
If you got that done in their bag.
I have no idea if the injectable amount is like a different volume. I'm curious if anyone knows.
I don't think there's a detail.
Sublocade is larger and it hurts.
Yeah.
I figured so.
Yes,
I figured, but I was
significantly larger.
So that could be another bonus for people. Yeah.
So all things equal. So let's say we had the REMS and it was available. So who would we choose then, for instance, to the Brixadi monthly versus the Sublocade monthly?
I don't have an answer for the monthly. But one thing I was talking to Dr. Moran about was the consistency and follow-up for patients. Some patients find a lot of stability in that weekly visit. And so more check-ins being more beneficial. So for someone that has a hard time remembering to take medications every day, filling prescriptions, that weekly dose could be beneficial, but still having a point of contact more frequently than monthly.
Pseudo
I-
OTP, yeah.
Kind of, yeah. I mean, I had a patient who was very thin, who had a real difficult time with the Sublocade because of that.
Yep.
And that would have been, Brixadi would have worked
Yeah.
much better for her.
But I think some of the steady state data and all that stuff, you need to get a better sense of how it actually is gonna shake out, but yeah.
I haven't met any patients like this yet, but some might find it helpful to have the depot and palpate it and know that it's in their system, kind of like the implant
Yeah.
for birth control. But I feel like most of my patients have not
Something
like
like
it.
Yeah, but most are not gonna prefer, I would say, the average, but.